Good morning, everyone. My name is Lisa Sutherland. I'm a registered midwife and a board-certified lactation consultant, and I live in Courtenay on the unceded territory of the Comox Nation, and I'm pleased to be with you all here today on the territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, and it is my honor to introduce Dr. Michael Klein to you all. Forgive me if I read a little bit here. There's a lot of credentials and awards that I'd love to share with you because he's well known and well loved. Dr. Klein is best known for his RCT, episiotomy, demonstrating that it caused the very trauma that it was supposed to prevent. This work is credited with contributing to a large drop in routine episiotomy use and a concurrent fall in rectal trauma. He teaches at UBC in family practice and at midwifery and is on the editorial board of birth. He was head of a McGill Teaching Center, Department of Family Medicine at McGill Teaching Hospital in Montreal for 17 years, and head of the Department of Family Practice at Children and Women's in Vancouver for 10. He is a recipient of the Order of Canada, the Award for Lifetime Contributions to Primary Care Research from the North American Primary Care Research Group, Family Physician Researcher of the Year from the College of Family Physicians of Canada, the Award for Lifetime Contributions to Family Practice Research from the College of Family Physicians of Canada. He is also the author of Dissident Doctor, Catching Babies and Challenging the Medical Status Quo. He and his wife Bonnie emigrated from the US to Canada in 1967 because he refused to be a military physician at the start of the Vietnam War. His son Seth and daughter Naomi were born and work in Canada, and his wife Bonnie is a disabled filmmaker, writer, disability rights activist. And please join me in welcoming Dr. Michael Klein.
Thanks. Good morning, everybody. I think I'm here to provide some comic relief as opposed to the dense material that you've been experiencing since yesterday. Just to start, how many of you are midwives? Obstetrical nurses, maternity nurses, pediatricians, obstetricians, public health people, community-based people? Who am I forgetting? Social workers, neonatal nurses. Yeah, great. So it's a wonderful distribution. You know, this is a conflict of interest of sorts. I don't know whether it's a conflict of interest or not. Some of the material that I'm talking about today is in this book, but the book is, in a sense, a birth book and not a birth book. And in some places it's really intensely about birth. In other places, birth is a metaphor because how we treat pregnant women and babies is a way of looking about our value system as a community. I'm going to tell you a little bit about my own involvement with birth, and it's a strange history that may be of interest. When I was a medical student at Stanford, I spent a year and a half in Ethiopia. I took a leave of absence and then graduated in the following class. And I was at the Children's Hospital in Addis Ababa. But when things got kind of quiet in the evening and babies were put to bed, so to speak, I, being a keen medical student, would often go through a short tunnel into a general hospital which was attached. And the midwives were very generous there, and they taught me how to attend births. And there was a problem with that, and that is that I hadn't yet had obstetrics and gynecology at Stanford. And that created a problem that you could say started it all. Now, the midwives were very good to me, and my problem was that by the time I returned to Stanford to complete a few things, one of which was obstetrics and gynecology, I had already attended about 200 births with the midwives, and that was a problem. So on my first day of my obstetrical rotation at Stanford, after attending a birth or two, I felt a very heavy hand on my shoulder, and it was the professor and chair of obstetrics and gynecology at Stanford, and he said, "Mr. Klein, come into my office." I didn't know what my crime was, and I followed him to his office, and he said to me, and this is a direct quote, he said, you know, on my service, every woman will have an episiotomy. And if she doesn't have one before the birth, she'll have one after. Now, I know you're thinking this is completely crazy, and I was thinking that too, but maybe it was a joke. I mean, I don't know. I didn't take it as a joke, but I thought it was a joke. And then he said, you know, if you want to practice primitive medicine, you'll have to go to the county hospital. So he actually exiled me to the county hospital, where I had an absolutely wonderful experience, because at the county hospital, where residents were running everything, I went to the head of pediatrics, and this is kind of pre-family medicine as an academic discipline in both the United States and Canada, because it's the late 60s, and the mid to late 60s. And so what I was doing, I was actually delivering babies, attending birth, and then looking after the children, which made a lot of sense to me. But family medicine hadn't been invented yet, and I hadn't been exposed to it, so I didn't know what I was doing. But in fact, it was, you could say, the beginning of family practice for me. Of course, I never saw a family doctor all the time I was at Stanford, so if you've never seen one, you couldn't be one. So as was alluded to in my introduction, Bonnie and I escaped to Canada because I didn't want to have anything to do with the Vietnam War. And I had started my pediatric residency in the States at Albert Einstein, and I completed it at the Montreal Children's Hospital, where they really looked after me very well. And went off to Rochester for a few years because what I wanted to study, which was community medicine, was not available in Canada at the time. So I ran health centers, developed and ran health centers, and finally discovered family practice and decided that that's really where I was meant to be. Recruited back to Canada in 1975 through McGill teaching program, where we produced a full-service family doctor, and including maternity care. Now, keep in mind that Medicare in Canada had begun in 1970, and I left in 67. By the time I'd come back in 75, Medicare had existed for about 5 years. And but going back to how things were in the 60s and 70s, so when my son Seth was born at the Royal Victoria Hospital in Montreal, I was the chief resident, and they tried to keep me out of the delivery room because partners were not allowed in the delivery room. Think about how far we've come. Then, a couple of years later, when our daughter Naomi was born, yeah, partners could be in the delivery room, but you couldn't take pictures. So again, you know, things moved. And so here, this is what it was like in the 60s and 70s. And we all dressed up, and we pretended that it was a sterile activity. And of course, we hope for more of this kind of thing. Now, in those days, if a woman actually did what this woman is doing, somebody would have slapped her hands and said, you know, you're contaminating a sterile field, which of course it's not. But we wanted more of this. And but after I'm truncating a number of things, but I decided, and you could say that it resulted from that whole early experience, but I decided to really study episiotomy properly. Now, there had been a number of studies of episiotomy by midwives, mostly in other jurisdictions, mostly in Europe. But, you know, North American physicians, mostly, and obstetricians really didn't read that literature because, I mean, who cares? You know, it was the midwifery literature. We don't read midwifery literature, and besides, you know, midwives do things differently than we do, so who cares? But we decided to do it properly, and we decided to do a classical randomized controlled trial, which is the only randomized controlled trial of episiotomy even to this day. Now, that was your basic study question. And just to back up here for a minute. So we decided that in order to really look at this properly, and this has become quite germane to some of the debates that are going on today, is we decided that we really had to make this look at real science because we had to convince skeptics. So we decided that we would actually measure the pelvic floor before delivery and 3 months after. And this is the device that we concocted to measure that. It's called electromyographic perineometry. Very, very scientific, right? It's Kegelometry, okay? And Kegelometry produces a record like this. Now, this woman is doing what we called flicks. So she's doing, there's a transducer in the vagina that is like a tampon, and you squeeze it and you get this kind of a record. You do a series, and then these are called 10-second holds, and you can see that this woman decays a little bit as she repeats them. But this woman's pelvic floor is very strong. You won't get a much better record than this. Now, this is a woman who has some difficulties, and this is a woman who's in deep trouble. But we could actually measure all of this before and after pregnancy. So I'm going to give you some of the outcomes. Now, I'm not presenting this to you to rehash the old randomized controlled trials, but to show you another way of looking at birth and the way some of the issues develop. So we're looking at pain of 697 women having their first births. And we have day 1, day 2, and day 3. And what you see here is that pain is less for women who have an intact perineum. And you can see here that tears are more painful than being intact. It's a no-brainer. But you may be surprised, or you may not be surprised, that episiotomy alone is more painful than tears. And if you've experienced a paper cut, may understand why. And of course, 3rd and 4th degree tears, severe perineal trauma, is most painful. And 52 out of 53 women in this trial who had such severe trauma had it in the presence of episiotomy. Only one woman in the entire trial had a spontaneous 3rd or 4th degree tear. All the others were in association with episiotomy, which is about as close to causality as you're going to get. And so here we looked at pain, receipt of medicines for pain on day 1, 2, and 10. And once again, you see the intacts are the least painful, the tears are less painful than episiotomy, and the severe trauma continues to be painful. And if we look at this 3 months postpartum, you see the same kind of pattern. But here, and I only want you to look at this part right here, we are comparing cesarean section against other outcomes. And you see that the cesarean section, pelvic floor functioning, strength of pelvic floor, and intact is the same, okay? And this is the only study that looks at that. And of course, you can see the people who have 3rd and 4th degree tears have pelvic floor functioning at 3 months postpartum that is compromised. So that's the summary of the main trial. That the hypothesis was that episiotomy would cause the very trauma, and it turned out to be true. However, and here's where it gets interesting, there were some physicians who were part of the trial who had an intact perineum quite frequently in their patients, and other physicians who never did. And there were some physicians who couldn't follow the protocol that called for limiting episiotomy use. There were others who seemed to own all the 3rd and 4th degree tears, and others who seemed to never have 3rd and 4th degree tears. So I'm sure those of you who work in delivery suites know that that kind of variation exists, and maybe in the discussion we could talk more about that. So for me, this was the first time to begin to think not just about the outcome of a trial, but to begin to see where the trial and the information fit, and how you go from your belief system to your behavior to the consequences. And there are severe consequences. And so before the physicians who participated in the trial had seen the results of the trial, we did a questionnaire that covered not only their beliefs about episiotomy, but everything else as well. And here's a question, one of the questions. And you could imagine that if they were positive about that question, they would likely be a big episiotomy user, which turned out to be true. And then, once again, if you believe that, that you could prevent pelvic floor problems by doing episiotomy, you obviously would do more episiotomies. So what we did then is we collapsed the whole trial, not into the two arms of those who were in the try to avoid episiotomy arm versus try to avoid a tear arm. Instead of doing that, we collapsed the whole 1,000 deliveries into one data set, and we divided them up, not on the basis of what happened to the woman or the randomization, but the behavior of the doctors. So there are many ways of dividing the doctors. I divided them into episiotomy skeptics and old school. We could have labeled them any number of ways, but what the slide shows is that the intact perineums, not surprisingly, are owned by the episiotomy skeptics, while the severe perineal trauma is owned by the people who seem to love episiotomy. Moreover, you might ask yourself, well, what are the cesarean sections doing in there? Well, the cesarean sections are women who risked out from the trial, but they still exist, and they want to be part of the trial, and they continue to come back for follow-up visits. And so what we see here is that the cesarean section rate for those who were episiotomy skeptics is much lower than everybody else. Now, these people see the world through episiotomy-colored glasses, and these people really think the perineum is a defective organ that needs to be managed. They also see, basically it's a defective organ that needs to be managed. And it's a totally different way of seeing the world. Now, as a result of this trial, and the work of many other people as well, the episiotomy rates in Canada and the US dropped precipitously, and what also happened, which was very reassuring, is we went from a third and fourth degree tear rate of 4.2% to 1.5%. So that followed because of restricting episiotomy use. So we had a 98% follow-up at 3 months for the people in the trial. That's a testament to the women who were really interested in the study question. So there were many questions that were asked then, and this was these are the two questions that we directed ourselves to. So here's a question. If you are currently having trouble with loss of urine at 3 months, is it severe enough for you to wear a pad? And what you see here is there is no difference between intact first degree, second degree tears, episiotomy itself without extensions, with or without extensions, and cesarean section. We find no difference at 3 months. And the reason I show this to you is because if you look into the existing literature, you see lots of literature since about 1993, 1994, when there's been a virtual explosion of studies of pelvic floor functioning, all of which are promoting cesarean section as a way of avoiding problems. And all I'm trying to show you here is that, in fact, at 3 months, there's really not much difference, that there are other factors at play. Are you experiencing pain or discomfort during intercourse? Well, here you see that the intact women have much less pain than the cesarean sections, and the intacts and the cesarean sections are about the same, and the episiotomy is associated with most of the pain and discomfort during intercourse. This is a kind of anomalous slide. It's on sexual satisfaction. You see there's no difference by whatever category you were. But note this last statement here. For each year of education, a 7% decrease in sexual satisfaction. This is one of these results that you don't want, and you don't understand, and you don't talk about very much except to make people laugh in conferences first thing in the morning. So in 1993, I was recruited back to Canada, rather from Montreal to Vancouver to head up family practice. And the reason that I'm showing you this stuff here is because it's quality assurance material that you all can do in your settings. It's very simple, doesn't require a vast number of cases. So we decided at BC Women's and Children's Family Practice Department to study ourselves very carefully. So there were at the time 169 family doctors in my department. There was no research going on, so we began thinking about that and doing research. And it was started as quality assurance and quality improvement and went on to research. So we wanted to, let's take a look at, I don't know what's going about this, but I think I'll skip it. Okay, so here's what we did. We began to look across all of the procedures and approaches that were used by ourselves, confidentially. And so this is the episiotomy rate for the department in about 1993. And here you see 15 doctors with an episiotomy rate of 0. And here you have 9 doctors with an episiotomy rate of 100%. And here you see a bell-shaped curve where there's great variability. Everybody clear about that, I hope? So here's the mean rate for the department, 47%. But what happened here is that on an annual basis, every member of the department got a package of charts like this. They got it for episiotomy rate and for forceps and vacuum for cesarean sections, epidurals, they would all see this. But on their confidential report, there'd be an X. And the X would be where their rate was in relation to the department. So here, for example, if the X was here, there are 14 physicians with a rate of 35%. Okay, anybody have any questions about the use of this? Okay, so here's what happened as time went on very quickly. Now, instead of 9 physicians with a rate of 100%, there's 1. What happened to the other 8? We don't know. They died or retired, but basically we don't know because, as you know, in quality assurance work, it's confidential. So as head of the department, I shielded myself from knowing, because all I'm interested in is not the individual, but moving the department in a particular direction. And that's what happened. And here we see how it happens. So the episiotomy rates drop, and as the episiotomy drops, look what happens to the 3rd and 4th degree tears. Same thing. And this is the epidural rates, same package. So here, 13 physicians with an epidural rate of 0, 1,700%, everybody else in between. How many of you believe that epidurals increase the cesarean section rate? How many of you believe it doesn't increase the cesarean section rate? How many of you are not sure? Okay, interesting, very interesting. Well, the Cochrane says that there is no increase in the cesarean section. The early Cochrane said that there was, but the current Cochranes and recent Cochranes say that there has not been. Well, let's look more deeply. So here within the department, we see first births and subsequent births. And we're looking at cesarean section rates by the way you use epidurals. So here we have an epidural rate for that physician of 0 to 40% and a section rate of 14.8. And look what happens as your epidural rate increases. Your cesarean section rate increases. So there are different ways of knowing. Large randomized controlled trial can teach you one kind of thing, but at an individual departmental level, you might learn something entirely different. It depends on your environment and the way you think about things. Now here you notice that epidurals do not affect the multips. You have to be a really bad doctor to screw up multips. You know, multips do well. However, if you look more deeply inside this, you see that those physicians, the first column, who had the low epidural rates, have the lowest rate of occiput posterior and occiput transverse. How many of you knew that epidurals actually increase malpositions? A few people know that. Well, the literature is very clear about that. And if you give the epidural in the parking lot, you definitely are going to cause occiput posterior. Because what happens is this is not new data from me. What happens is if you do the epidural before the baby is engaged, the pelvic floor is relaxed, and the baby doesn't descend, and the baby doesn't rotate. And so you get a malposition. Now, what you get from early epidural use is more use of oxytocin augmentation, no surprise. And, you have more spontaneous vaginal deliveries and fewer cesarean sections. Okay. The most disturbing aspect of this little study was the babies. So what we did here is we look at 5-minute APGAR scores according to low epidural users and high epidural users, 2.8 to 4.8, and SCN and NCN admissions, 6.9 to 11.7. So it looks that there is an association, at least, between high epidural use and extra admissions to the special care baby unit. Very hard for people to accept. Okay, I'm going to move into a different kind of research, but it isn't really different, because you can see that Janusz Kazarowski and I, he's my main collaborator. He is he's currently at the University of Montreal, but he was a graduate student at the time, and he and I worked together for many, many years. And so we looked deeply now at attitudinal issues and how they impact on practice. And so we did a national study of a large number of obstetricians, family physicians, midwives, nurses, and doulas. And I'm going to show you some of the data from that study. So here's a question. I support licensed and regulated midwifery services. And you'll be pleased to know that 71% of obstetricians at that time, which is about 7 years ago, believe that. Of course, doulas are the, I forgot to ask about doulas. How many of you are doulas? A few. That doulas were the greatest supporters of midwives. However, while we love midwives, we hate half of what they do, which is home birth. And so those same, mostly obstetricians who supported midwifery really were not comfortable at all with home births. Now, I have to say that this result would be different now, because since this study, the work that Patty Jansen and some of us in the room have done, and where we looked at all the home births in British Columbia for 5 years, and clearly showed that home birth is as safe as hospital births for both mother and baby. And the College of Family Physicians, the College of Physicians and Surgeons of British Columbia, on the basis of that study, rescinded its longtime prohibition of family doctors, or any doctors, having anything to do with home birth. If you did, you'd lose your license. And that's not true anymore. And it's true, that's because of that study. So there's a need for doula services in maternity care. Registered midwives are very strongly in favor of that, which is excellent. Obstetricians are kind of neutral. They're kind of wishy-washy about the need for doula services. It's a woman's right to choose cesarean section, even in the absence of indication. Well, 42% of obstetricians believe that, but look, they're not the only ones who believe that. This is everybody else. So what do you think is going on here? Is it because they believe that cesarean section is as safe as vaginal birth? Or is there some other factor? Anybody have any hypotheses? Well, in my view, there's a tension here between a belief that cesarean section is more dangerous than vaginal childbirth for mother and child, and the issue of maternal autonomy. And we're all caught on that autonomy issue, and it's still playing out right now. Epidural analgesia interferes with the normal process of labor. Well, more than half of obstetricians disagree with that. And here you see that the people who are closest to them are family doctors who only do antenatal care, some family doctors who do intrapartum care, but the people who really feel this is very strongly a correct statement are doulas and midwives also. All right, but if we break it down by age of obstetricians, it gets kind of interesting. So here we see that we divided the obstetricians into 40 and over and 40 and under and over 40. So the over 40 obstetricians are more likely to say that epidurals interfere with normal process of labor. And they're more likely to think that it increases the incidence of instrumental birth, which it does. So what's going on here with this generational phenomenon? Why is it that the older obstetricians are more likely to believe that epidurals cause these interferences? Anybody? Experience. Exactly. So the older obstetricians were present in the transition from a time when epidurals were not readily available to the time when they are over available in some cases. And so they saw the change. The younger obstetricians have been educated in an epidural soup. They've never seen anything else, and so that's what they believe. Epidurals increase the incidence of instrumental labor. Well, there's a disagreement of 30% among the obstetricians. The others are more skeptical. It's the same story in the slide that I just showed you. Cesarean section prevents urinary incontinence. Well, half of the obstetricians disagree, about a third agree. In other words, it's an issue, and the issue has to be dealt with. Cesarean section is safer for the baby than vaginal birth. 18% of obstetricians believe that. And safer for the woman, 20% of obstetricians believe that. Now, who are these obstetricians? And you know, where are they located? And who's looking after the women? And who is looking after the women in a collaborative way? And you don't learn that from this kind of slide, but you see that there's tension here. And that tension gets played out on the labor suite, as you all know. Now, the good news about episiotomy is the younger obstetricians really have got the message that routine episiotomy should not be done. And this question here is very interesting because vacuum and forceps used to be an indication for the use of episiotomy routinely. And it looks like that there is some skepticism, but the new generation is more likely to disagree with the fact of putting instruments and episiotomy together. Now, I'll tell you of a very interesting study that took place in another location by someone named Ecker. Within his own department, as a matter of principle, they disaggregated episiotomy use from vacuum and forceps use. Because previously, whenever one of the instruments was used, an episiotomy was used. And they decided, as a matter of departmental policy, not to connect these two things. In other words, you have an independent decision. Do you need forceps or vacuum? Okay. Can you do forceps and vacuum without episiotomy? Some people thought no. Well, in fact, once the baby gets down to crowning, you could take off the vacuum or forceps, put them away, and deliver spontaneously a lot of the time without trauma, and at other times you may have to do an episiotomy, but the point is that it's not routine, and it shouldn't be routine. Now, I find this a rather disturbing slide because we're talking about the mother's role in her own birth. The question is, for a woman having a vaginal birth is more empowering than delivering by cesarean section. Well, there's more of that belief among the older generation than the younger. Women should be encouraged to develop a birth plan. Well, less so among the new generation. Cesarean section is like any other birth, more so among the newer generations. And this is statistically not significant. It's a woman's right to choose cesarean section for herself. We saw that in earlier slides. However, I fear vaginal birth for myself or my partner, as it may lead to urinary incontinence. The younger generation more likely to believe that it might also increase sexual dysfunction, fecal incontinence, pelvic floor damage. Well, where did they learn that? Well, you know, we can talk about the educational aspects of this. Being a little cynical, if you spent as an obstetrical trainee 6 weeks in a urogynecology clinic and no time with a midwife during your training, this is the kind of issue that might come up. This is the way you might see childbirth. And what we know is that depending on the site, somewhere between 20 and 50% of the new generation of obstetricians are deciding never to experience vaginal birth. And they're having preemptive cesarean sections for themselves. Now, if they do that, you can imagine what they are advising their patients. Now, even since these early episiotomy studies, there's always been some pushback, people who really felt we'd gone too far. And a couple of weeks ago in the Canadian Medical Association Journal, there was an excellent study, which I've cited here. They actually studied 2.6 million births across Canada. That's a pretty good sized study. They looked at episiotomy use and outcomes, perinatal outcomes, and pain. Well, they couldn't study pain. Perinatal outcomes. Now, they got this from the CAI database, which is where all of this information goes from all deliveries. So just think about it now. We have a huge database here. I mean, this is really a spectacular study. It's retrospective, and you can dice it and chop it up in different ways, which is great when you have big numbers. Now, their study confirmed our work and the work of others that showed that episiotomy use routinely is associated with increased maternal trauma and the very things we were trying to avoid. So they confirmed that. I guess I should feel good about that. However, what they point out is that with the passage of time, there is an increase in third and fourth degree tears among women who had instruments and did not get an episiotomy. So this study is raising the question about whether we've gone too far. At least that's one way of looking at it. The problem here is that association is not causation. So this is an important study. It's getting a lot of play right now. Association is not causation. All we can say is that something is going on. We don't know what it is that's going on. It may be that there is an underuse of episiotomy in the presence of forceps and vacuum, but this study can't show that. We have to look at a study to really learn more to find that out. And the problem is that in a vast study like this, that's retrospective, you don't really know what's going on the shop floor in individual settings. You don't know whether people are actually doing what I described earlier, which is to bring the baby to the pelvic floor, to crowning, and then putting your instruments away and considering it as an opportunity for spontaneous vaginal birth. You don't know that. at the individual setting, and you don't know how people are actually behaving. So all a study like this can do, and it's worth looking at for sure, is to raise a question that says, what's going on here? At the same time, women are getting older. Women are having their babies later. There may be an increase in obesity, a number of factors that are coming into this, and that needs to be looked at very carefully. So, one time for questions, I want to do a little plug here. Are any of you part of the maternity care discussion group that I run? Okay, a few of you. So this is the only multidisciplinary maternity care discussion group worldwide, as far as we know, and it is made up of 1,800 family physicians, obstetricians, midwives, doulas, some policy people, obstetrical nurses, and I established this discussion group 33 years ago. And I'm still the list master. I should have my head examined. But it is an opportunity for people to dialogue with other people in the field. So it is used for clinical problem solving. It's used for establishment of the research. It's a self-help group. People get, Mrs. Jones is moving to Calgary and I can't look after her anymore. Is there anybody who'll look after her? That kind of thing. But it's very active, and we post articles that are good and talk about why they're good. We post articles that are terrible and talk about why they're terrible. So it's an opportunity to sort of, look at the literature. For example, a few months ago there was an article that showed an association between cesarean section and autism. And it's utter nonsense, but it was getting a lot of play in the media, so we thought we better have a look at that. So I think at this point I'd like to stop and have some discussion about what all this means and where you situate yourselves in this ongoing debate, where we have childbirth is nothing more than an accident waiting to happen. Childbirth is a maturational experience that should be celebrated. It's reasonable to be vigilant, but it is a normal phenomenon. Now, these two paradigms are completely at odds, and we have no idea how that battle is going to work out. Reread The Handmaid's Tale, and you'll recognize that some of the issues raised in that wonderful book are real. So thanks very much. I'd love some questions. Yeah.
There is a microphone at the back, or if you have a loud voice, just
Try and use the mic, it's better.
yeah.
Because the other people can hear.
Thank you
Yes.
very much for the presentation. It was very, very, very good. I really enjoy it. My name is Isabelle Baribeau, and I'm a clinical nurse specialist at St. Paul's. I was wondering, you talk a lot about the obstetrician, the registered midwife, doula, and I was wondering if you were able to look at the work of nurses. I know that nurses in labor and delivery are the professionals that spend the most time at the bedside with the patient, and the care that they provide impact outcomes. I know that in the literature it's not very well researched, the impact and outcomes of nurses on the actual birth. I'm aware of one study like Radin that did in a study about the attitude of nurses and the impact on outcomes, and identified that the attitude of nurses totally impact the way she work with the woman or manage the labor. So I was wondering if in your studies you were able to look at the impact of nursing care on birth outcome.
So in the study, we measured in the national study, we measured the attitudes of nurses across the country, but you're not asking that question. The nurse studies in this area are very complicated and difficult. It must be at least 30 years ago, Patricia McNiven, who is a midwife and a nurse at McMaster, did a time study, a time motion study of nurses in labor, and found that the new generation of nurses were spending, you may find this hard to believe, only 15% of their time hands-on with the patients. The rest of their time, because of the enormous pressures on them from the institutions, they're charting, they're hooking up IVs, they're dealing with the monitoring equipment, and they are spending less time than the older generation of nurses spent when in supporting women in labor. So it's very hard to know. Now, there is one study by Alan Hudnett, who is a nurse researcher, who actually they trained nurses to be doulas. And it was Alan Hutnett's experience or hypothesis that a doula-trained nurse would have better results than a nurse without that training. And it turned out not to be so. That the results, it was a randomized controlled trial, and the results for the doula-trained nurses and the non-doula-trained nurses were identical. And the reason for that is because a nurse can't be a doula. Nurses work for the institutions. They are responsible to the institutions. They can be sanctioned by the institutions. Well, doulas have only one role, and that's to support women in labor, and they are unconflicted with any of the organizational stuff. I think that the new generation of doulas, of obstetrical nurses, have a hard time doing the support work that they themselves know that they should be doing because of institutional constraints. I don't know whether that in any way answers your question, but it's a troubling area. Other questions?
Hi, Sarkali Sankova, Obstetrics and Gynecology.
I'm having trouble hearing you.
Sarkali Sankova, Obstetrics and Gynecology. Thank you for your presentation. I just wanted to point out about urinary incontinence and pelvic organ prolapse. There is a body of evidence that does show that vaginal parity and especially obstetric trauma leads to higher rates of urinary incontinence or pelvic organ prolapse in 10, 20 years down the road, which is not true for fecal incontinence, which is interesting. But in some way, we should be cognizant of that and maybe be upfront with women that this is actually the evidence that we have currently. On the other note, I think that posing a question whether cesarean delivery is as safe as vaginal is not really a good question, because in some cases, cesarean delivery will be safer than vaginal. If we see that there are complications that can occur down the road, it's safer to do the cesarean section and vice versa. So I think the approach should be the individual approach to every woman, every case.
each kind of provider, obstetricians, family doctors, and midwives, are actually needed, and where they should be trained, and who should train them. And then the system should be designed for that. Right now, it's just catch as catch can. I mean, the obstetricians decide how many obstetricians, family doctors the same. Midwives have increased their production enormously, but these are not being made, as a real healthcare progressive decision about what the province and what women in the province actually need, as opposed to what we professionals need. That's the most important thing.
Morning.
Yes.
Tamara, I'm a pelvic health physiotherapist, and I thank you very much for your talk, and I appreciate you bringing up the word pelvic floor, because it seems a lot of women that I see in my practice often don't even know what that is, what it entails, what its job is, how it works in birth and postpartum, and recovery to exercise. So one curiosity I do have is, with your research, there was an initial study that you spoke about where you were using that probe to assess their ability to contract. Did you also...
I'm missing a little of what you're saying.
Sorry, to assess the ability of them to contract their pelvic floor, one of the initial slides. Did you also assess their ability to relax their pelvic floor? Because I find in practice that a lot of women are somewhat misdiagnosed, or whatever word you wanted to use, but that they actually have a weak pelvic floor, but they do not. They're actually already high tone. And then, of course, that doesn't obviously allow them to have sometimes successful delivery and so forth, which could lead to tearing or use of instruments or whatever. So on that note, I'm curious if you have a pelvic health physio that does work with you in your group to determine, screen prenatally and then assist in, postpartum recovery.
Well, the answer is no. There are physiotherapy groups, one at Women's, who are dealing with pelvic floor issues all the time, and that they're a very essential part of the team. But I am unaware of any research. You can talk to me afterwards if you know some, that talks about relaxation of the pelvic floor ahead of time, ahead of the birth. Obviously, if a woman has urinary incontinence, urge incontinence or stress incontinence before the pregnancy, she should go to get proper pelvic floor teaching before the baby arrives, because that's the woman whose birth is likely to be, whose pelvic floor is likely to be harmed by her birth, because she's already got a problem. So those women should get pelvic floor education in advance. If that helps.
Dr. Klein, thank you for your legacy of the work you've done over the years. My question is, if you had one piece of advice for us moving forward in how we train physicians and nurses, because fish can't see the water, what piece of advice would you give us, one practical difference we could do in terms of training?
Well, I don't think there's one piece of advice, but basically I think that, and I include medical students here. Our medical students spend most of their time in their training looking after complex cases and assisting at sections, and come on in, we're going to do a forceps rotation. And in other jurisdictions, students spend time with their patients throughout labor, and they learn something entirely different than if they only attend complicated births, because if they only attend complicated births, they think that childbirth is complicated and at-risk activity. So I think the major issue to improve a lot of this is to have student midwives, student nurses, and student physicians training together. We do that to a certain extent at Women's. At the beginning of the rotation, for medical students, there is a workshop on day one, which is co-taught by obstetricians, family doctors, midwives, and doulas, and they immediately can see the contribution of each. But that's not enough. That's just a beginning. I think that obstetricians need to train with midwives. Midwives need to spend time with obstetricians. Family doctors need to spend time with both. And that's the way we will learn together and have an opportunity to create models that work well. And we have good examples of that across the province, and we need to get the ministry to change their finances so that people can more easily collaborate, and that's important. Some of these groups that exist right now are actually pooling their income. The midwives are throwing all their income into a pot, and the family doctors are throwing all their income associated with birth into a pot, and you're paid out of that pot on the basis of what you actually do, and you get paid the same thing for doing the same thing. And there are very few of those, but they are growing in number, and I think that'll be become a training model as well. But the most important thing, I think, is for obstetricians to really train in their role as consultants to midwives and family doctors in that consultant role, while they also spend significant time with midwives so they can appreciate some of the nuances of normal birth, while they are also associated with normal birth, they spend, of course, a disproportionate time in complex births, and they often get that affects them in the way you'd expect it would affect them. Yeah. I mean, for example, we asked the question about the use of induction for post-term pregnancy, and 88% of the obstetricians felt that births should be expedited at midnight at 41:03 when we know the placenta implodes, right? So some of you appreciate that bad joke. But we need to appreciate why they believe that. And they believe that because they see stillbirth. They see their stillbirths, and they see our stillbirths as family doctors and midwives. And stillbirths are not a lot of fun. And so we need to appreciate that that's why the obstetricians believe what they believe. But we need to look deeper into the consequences of that belief, and what it means for subsequent pregnancies as well as the index pregnancy.
Thank you.
Hi.
So sorry, we are at time. I'm so sorry. We need to cut off the discussion. Thank you very much.
You're most welcome.
And
Thank you.